Welcome to Buffalo HealthCast, the official podcast of the University of Buffalo School of Public Health and Health Professions. We're your co-hosts, Skylar Lawson
and Tia Palermo.
In this podcast, we cover topics related to health equity in Buffalo, around the U.S., and globally.
This season, we'll be talking about nutrition from a health equity perspective. You'll hear from community members, practitioners, researchers, students, and faculty on topics related to nutrition, including food security, food access, social protection to improve nutrition outcomes, food apartheid, culturally tailored nutrition interventions, and more in this season of Buffalo HealthCast.
Hello, everyone, and welcome to another episode of Buffalo HealthCast, the University of Buffalo's premier public health podcast. I'm your host today, Nicole Klem, a registered dietitian and director of the Clinical Nutrition Graduate Program in the School of Public Health and Health Professions. It's National Diabetes Month in November, and the CDC estimates there are 34 million American adults living with diabetes, and an estimated 88 million more may be at risk of developing the disease. Hispanic or Latino people make up a diverse group that includes people of Cuban, Mexican, Puerto Rican, South and Central American, and other Spanish cultures, and all races. Each has its own history and traditions, but all are more likely to have type 2 diabetes, 17% more likely than non-Hispanic white people, who have an 8% chance of developing diabetes. But that 17% is just an average for Hispanic or Latino groups. The chance of having type 2 diabetes is closely tied to background. For example, if your heritage is Puerto Rican, you're about twice as likely to have type 2 diabetes as someone whose background is South American. With us today is Maria Aguero de Manunta, a registered dietitian and owner of a local private practice and clinical director of the Clinical Nutrition Graduate Program. Thank you so much for taking the time to speak with us today. So I'll begin by asking you to tell me about yourself and why you started in nutrition and became a dietitian.
Hi, so I am originally from Paraguay, South America, and I moved to United States with my husband and 4 children in 2001. We love Buffalo, and now it is our home. I chose to become a dietitian because of my love for food. I grew up in a German town in my country, and one of the traditions in the town was baking wonderful German cakes and cookies. And we, after we finish with everything, we share all these delicious pastries with friends and neighbors. And I can say that my love for food started when I was very young. I have always interested in working in the healthcare field to help others, and I saw that becoming a dietitian was a perfect career for me. And I always wanted to learn more about food and healthy eating. So I think when I started my nutrition career, this one, I learned a lot, and I feel that I can help my patients and even friends and family who ask me about what is the maybe best food to eat if I have elevated cholesterol.
That's really exciting. So this year's Diabetes Awareness Month is It Takes a Team. Does the dietitian work together with other healthcare providers?
Yes, the dietitian work with other healthcare providers in the team, and we call this the interdisciplinary team.
So what is the role of the dietitian on that interdisciplinary team? And then what barriers do Hispanic and Latino communities face getting to that team or accessing that team?
The role of the dietitian in the interdisciplinary team is to work closely with other providers to manage and improve patients and the community health. As a member of a team, dietitians can help patients to meet their needs, not only about nutrition, but about any concerns that the patients can have. Because we are very closely working with providers and this interdisciplinary team, if our patient needs to to make an appointment with the dentist. So we are there so we can contact the patients and the patient can get that appointment faster because we are there. And sometimes we talk with our patients, and sometimes the patient said, okay, I really would like to see a counselor. So we have a counselor if we don't have in the place where we are working, we can refer to some counselor in the area, so that we can guide our patients, not only if they have any nutrition concern, but about other concerns. You mentioned what barriers do Hispanic and Latino communities face accessing that team. When I did my master in nutrition science, I had to work on my thesis, and the topic of my thesis was assessing barriers that prevent treatment compliance in Hispanic adults with type 2 diabetes. And what I found was that the most significant barriers were lack of transportation and language and communication. My patients always said that they prefer to receive information in Spanish when they go to see their doctors or any providers. But sometimes they say that the doctors give them educational materials in English, and they cannot understand most of the information. Or I have a lot of patients that they cannot come to their appointments because they don't have transportation, and Medicaid offered a cab or taxi. But sometimes they said, I had an appointment with my doctor or with you, but they didn't show up. The driver didn't show up, or the driver called and said, no, I cannot come. So, and they miss their appointment. So I believe that lack of transportation is a very important issue for them. The other barriers were access to health care and other providers are related to lack of health insurance, so they cannot pay out of pocket their consultation with the doctors, or if they have some oral health or oral problems, they cannot go to the dentist because they say that it's very expensive, they cannot afford it. So the limited budget is another barrier that I found. Other thing that I found was family support and environment influence. So when they mentioned about this, they said that sometimes they want to follow maybe a healthy diet because the patient have diabetes, but because they have to buy the food, and it's going to be very expensive just buying for the patient who have diabetes. So they said that they have to cook the same food for the whole family. And sometimes they said that they don't find that support in the family. So they, if they have to follow like a diet maybe very or low in sugar, especially refined sugars, and they said, oh, my husband brought for me some donuts or cookies, and I cannot say no. So those are the most important barriers that I found on when I did my thesis, and the result those were. And these results demonstrate the need for qualified providers, dietitians who speak Spanish fluently and understand the diverse Hispanic culture.
All right, thank you. It must be a challenge really to overcome some of those barriers because of the limited numbers of providers that speak Spanish, particularly in areas like Western New York versus other, more Hispanic or Latino dense communities. The CDC estimates that 1 in 2 people of Hispanic and Latino background may actually develop diabetes in their life, but it's due to so many reasons. Sociocultural factors like lower income, like you mentioned, decreased access to education and to healthcare, again, points that you made that are barriers, which may be due to a combination of language barriers, lower high school graduation, employment in lower wage jobs, some genetic susceptibility to obesity, and higher insulin resistance. Racial inequity is also embedded in that healthcare system. So despite growing numbers of Hispanic and Latino communities, Can you help us understand or explain why these communities are still underserved by dietitians, and how do you see things changing?
As I mentioned before, many Hispanic have a hard time accessing dietitian services because they do not have health insurance, or the health insurance that they have do not cover dietitian services, and they cannot pay out of pocket because I believe that dietitians charge maybe 80 to 120 an hour for their services, and they said that that is very expensive because some patients explain me that if they go to see a dietitian and they have to pay $80 for the dietitian service, and then they are not going to have the money to buy the food. So it's depend if the patient really doesn't have a limited budget. I think they have a very hard time to make and see a dietitian. I think that what needs to happen is that health insurance providers need to cover medical nutrition therapies in the same way that they cover other medical specialties.
How do you think that nutrition education and counseling could be made more accessible to the communities?
This is a complex social issue that needs tackled from different fronts. The main one is education, so that the community can understand what needs to be done. The professional community to raise awareness of the importance of these therapies. Because I think dietitians when they are doing their counseling, it's not just to help patients if the patient have diabetes, but it's to prevent disease. So we are here to counsel or to provide nutrition education to prevent maybe the patients can have diabetes in the future, can have cardiac events, can have hypertension. And also government agencies need to work with insurance providers to make nutritional services available to the larger population. So, and according to Healthy People 2030, the goal is to reduce the economic burden of diabetes along with the disease, and to improve the quality of life for people at risk or who already have diabetes. And one of the objectives of Healthy People is to reduce the amount of new cases per year of diagnosed diabetes in the population, and to reduce the diabetes death rate.
Yeah, I hope we make some progress on those goals, unlike some other goals, and we see some reward for that effort.
Yeah.
Would you tell me a little bit about your experience working at Neighborhood Health Center and with our Spanish-speaking Western New York community?
Yeah, Neighborhood Health Center has different locations, and one of their location is called Matina, where I worked for 6 years, a little bit more. And the majority of their patients are Hispanic. They are really always looking for providers who speak Spanish, and they have a lot of representative, the staff who speak Spanish, and and this staff really help patients with all their needs. I was working as a clinical dietitian there, and the 80% of the patients that I saw were Hispanic speaking, so 80% of the patients that I saw every day. And they were really very happy because they every time when I am with them, they said, oh, I am so happy because you speak Spanish and I can understand every single word that you say. Because if you speak Spanish, you can understand everyone in the world. If the person lives in Uruguay, I am from Paraguay, from Puerto Rico. So there are going to be maybe little words that are different, but that doesn't mean that we cannot understand someone who speaks Spanish. I can speak 100% or maybe 99% person who speaks from Spain. So that's why the communication is very fluent. So we don't have any problems. So, and we also understand their culture. I learned a lot about Puerto Rican culture, Dominican culture here, because when I was living in my country, we have our culture related to foods is a little different than food from Puerto Rico or from Dominican Republic, but I learned a lot with my patients and I love their foods. And when I mentioned to them the food that we eat, they said, oh my God, I want to try that food too. So there are very similar foods, but they are very different. Like when I was living in my country, I think I never tried tacos until I came to United States. So I learned about Mexican food here in United States. So yeah, but so Neighborhood Health Center, they have one program that is called a sliding scale fee program. They provide some discounts for patients who qualify so they can offer their services to see dietitians, dentists, doctors, any providers there with a very low cost.
Wow, what a great service and what a nice sort of patient care model, for our Spanish-speaking community in Western New York. In your experience, what kind of disparities do you see between the Hispanic and non-Hispanic communities in Buffalo related to diet nutrition?
Based on my experience, I noticed that the Hispanic population has a higher tendency to acquire type 2 diabetes compared to the non-Hispanic population. Other things too is because the low budget, they cannot go to the gyms or do physical activities, especially during the winter time. And so they start having more problems about elevated cholesterol, hypertension, and of course that, and then they can have some any other health conditions.
You do see it a little more often just because
Yes.
of some of those maybe, socio-cultural
Yes.
barriers they've got or different, living conditions.
Mhm.
In general, and I want to say even in education, we sometimes hear that Hispanic diets are unhealthy. High sugar, high fat from fried foods. But is that true? And would you tell me a little bit about the foods and recipes in the Hispanic diet and where maybe the bias or the assumption about their foods has come from?
The Hispanic diet is not one, but many. Depending on from what country a specific community comes from, diets vary greatly. But in general, these diets are like most. They have good things and not good things like everywhere, I can say. On one hand, it is true that there is a high intake of sugars and fats. But on the other hand, Hispanic communities tend to avoid processed food and give preference to fresh home-cooked meals. So most of my patients mention that they cook at home, but sometimes of course, they go to Burger King, McDonald's, restaurants, but they cannot even afford to go many days, like maybe, I don't know, 5 times per week, but maybe sometimes they go 1 or 2, but they really cook at home. When we go and review their eating habits, I know that some cultures, they eat more rice and beans than other culture, or maybe less vegetables. But one of my patients explained me that in Puerto Rico, they don't eat too much vegetables because they don't have a lot of vegetables over there, or maybe in the area where this patient was living especially. And he said, so that's why they eat lettuce and tomato. But like in my country, we don't have maybe broccoli. So we are not used to eat a lot of broccoli. If someone wants to eat broccoli, maybe, I don't know, they have to pay more than just buying lettuce and tomatoes. The same in Puerto Rico, but that doesn't mean that we don't eat vegetables. And there are some foods that are high in fat, such as the pork is called pernil in Spanish. It's so good. I love it. And this food, it's very high in fat, but you can make a very lean pork too and very lean pernil. And they have another meal that or food that rice and beans or rice with gandules. So their gandules are very similar to beans. And they make some dessert that one of their cake is called torta de tres leches. Is very good. And made like I can say donuts. Those are high in sugar, but they don't eat like every day. So it's more like in special occasions. The other dessert is called flan. I love it. So yeah, they have some food that are high in sugar or fat, and some bananas, fried bananas that I love it. But once they start learning about, they see the dietitian, they learn that they can still have those foods, but in moderation. It's not like they are not going to have for the rest of their life. If they have diabetes, sometimes they can have it, but they create a healthy routine. Some patients who really needs to make some changes in their diet.
Where do you think some of the assumptions that it is unhealthy have come from? Do you think it's just because we see brown rice, chicken, and broccoli as healthy, and we don't see rice and beans and lean pork as healthy? Or, yeah, where do you think some of the, I don't know, assumptions that diet is unhealthy have come from? Because you're right, we have chicken wings and donuts and pizza, plenty of unhealthy things in our diet, but we maybe aren't as critical or judgmental on, the diet we eat here versus a different cultural diet.
Yeah, so I think it's because maybe the portion sizes that what they are eating, because they love Puerto Rican. People love rice and beans, and when I mentioned that to my patient that they have, or what is the portion size that you are eating about your rice and beans. So, and I said, show me about the feast of your hen. So they start laughing when I show them that the recommendation is to have one feast of the hen. And they start laughing. They say, oh my God, maybe I have 2 or 3 or 4 or full of my plate. So, but once they learn what is the recommendation about starchy vegetables and grains, they start cutting down the portion sizes. And of course, they have, as I mentioned, like fried bananas or other foods that are high in fat. But I believe that maybe that is more related to the portion sizes.
And I guess you kind of led into my next question, because if there is some truth to that, maybe the portion sizes are a little bigger of foods. Are there specific recommendations that you give them to modify their diets while still telling them they can include some of these favorite foods? So maybe reducing the portion size slightly. Are there other tips that you give them to enjoy the foods that they enjoy, but still, move towards maybe a more, healthier choice overall?
Yes, and as dietitians, we have to be very careful when we provide nutrition education to our patients, because we have to take into considerations their culture, their belief. So we cannot just go with our patients, even not just, I would say not just Hispanic, any person in the world. We have to learn about their cultures, their preferences. We cannot just go to a patient or a patient who is Asian patient, who they love rice, and we cannot say you cannot eat rice anymore. So we have to go and understand what they want and what they believe. And then, of course, we can start with our nutrition education and recommendation. And because there are as other factors, like, I don't know, maybe that is the biggest factor is the one of the budget. So we cannot recommend a patient to eat salmon if the patient have elevated triglycerides, but there are options. So we can tell the patient you can eat tuna fish, which is cheaper, or they can get from the food pantry. So we have to be very careful about that, and any recommendations that we are giving to our patients, and understand first what our patients want. And based on that, we can start and do, I don't know, all the recommendations. I always recommend my patients to have the rice and beans or rice with gandules in moderation. I recommend them to have half of their plate with starchy vegetables, or if they cannot go so fast to that portion size, I told them gradually, maybe you can start reducing that and adding more starchy vegetables. And we go over to how to prepare meals, maybe better bake or grill, like chicken or any meat, lean meats. And you are not going to believe, but at the next visit, they said, oh, I buy the air fryer. So they want to make those changes because they know that this is important for their health.
Yeah, that sounds like small changes could really add up, but also preserve some of their favorite flavors or foods or dishes.
Yes.
So where do you go to find reliable resources or tools for your patients or for Spanish speakers?
I go a lot to myplate.org because they provide a lot of recipes in Spanish, in English, even they have now in so many different languages. So if I have a patient from Arabic or Africa, they have a lot of options now. So in those languages, and when I was working at Neighborhood Health Center, we develop educational materials. I see now they have 5 different languages. So Arabic, I cannot remember very well, but they have a few educational materials in other languages. So myplate.org is a very good resources, very reliable. Centers for Disease Control and Prevention, the CDC, they have materials in Spanish, and the American Diabetes Association.
Yeah, really fantastic resources for us to build our toolboxes. Well, thank you. This has been really wonderful. Is there anything else you'd like to share?
I believe that it is important of providing more bilingual services and qualified dietitians who speak Spanish fluently and understand the diverse Hispanic culture, as well as funding for programs to reduce the financial burden of this segment of the country's population. Because low income and a relative lack of financial resources can severely impact a patient's ability to treat diabetes and other chronic conditions effectively.
This has been another episode of Buffalo HealthCast. Thank you to our guest, Maria Aguero de Manunta, for taking time to speak with us today. I'm your faculty consultant, Nicole Klem. Sarah Robinson is our production assistant. Omar Brown is our sound editor. And our theme music was written and recorded by Sungmin Shin of the UB Music Department. Again, my name is Nicole Klem, your host and writer for this week's episode, and thank you for listening. Tune in next time to learn more about health equity in Buffalo, the U.S., and around the globe.